right, so my name is Emma, for those of you that have no idea who I am. And today we're going to just talk a little bit about HIV and AIDS. This is obviously an infectious disease topic, a very complex topic. It wouldn't be a virtual rounds presentation for me if I wasn't talking about something complex. So we're going to touch on that. No fear, it's going to be at a level that you all can understand. So we'll kind of break it down and kind of talk about the things that you should know at the level that you're at. Like last time I talked to you guys, if my internet gives any problems, just let me know. I can always repeat anything or anything like that. I'm hoping it doesn't fail you guys this time, though I kind of perpetually have problems with it. But let me know if it gives us problems. We'll kind of troubleshoot it as we go. Don't be embarrassed to kind of scream out in the chat or stop me if I'm talking and you can't hear what I'm saying, or if it's skipping or whatever. All right, so let's keep it moving here. So real quick, we have a deal going on with our planner, kind of this buy one get one free deal, aka you can buy one for yourself, and then the free one is your Christmas gift for one of your friends, or whatever you kind of see fit. But here's the instructions for that. You can use this coupon code here. And go ahead and use it. I thought it was cool. I didn't know this about the planner, but it doesn't have any dates on it. So if you wanted to treat yourself, buy one, get the second one free, and use it for 2 years in a row, whatever kind of works for you. So it's not dated, which I thought was cool. I didn't know that. Okay. So as we were going to talk about, we're going to really cover infectious disease. And as you guys probably know, I don't have Facebook or any social media, but it appears as though everybody has kind of become their own infectious disease expert on Facebook, of course. So let me launch our pre-poll and sort of give me an indication of where you guys stand in terms of your knowledge about HIV and AIDS. There's like one person that hasn't answered. I'm very hopeful that the person that hasn't answered will. I'm very ambitious tonight. All right, so here we go. Here's the results. A lot of you said you know a little bit, and I think perhaps it's because HIV and AIDS has become something that is, more in the media. We're learning more about it, which I think is good, and it's starting to sort of destigmatize HIV and AIDS, which is excellent. That's really the direction that we want to go in. So it looks like a lot of you said you know a little. 21% of you said you know some, and 14% of you said you know nothing, which is perfectly fine. Wherever you kind of lie at on this spectrum here, we'll see if we can't teach you something and have a little bit of fun kind of in the process here. All right, so TikTok University is where you learn all things. Facebook U is too expensive. That's fair. That's fair. Okay. So if this is your first time with us, welcome. Here's kind of a breakdown of what we're going to do. If this is your millionth time with us, still welcome. Thanks for coming back. I do see a few familiar names out there, which I appreciate. I'm very humbled that you guys come back and listen to me talk for an hour. But what we're going to do this time, I have one case this time. I don't have the mini cases. Primarily because we're talking about one specific topic as opposed to kind of a broad topic where I'd want you to know multiple things about it, or there's multiple different pathologies under an umbrella topic. So for this one, we're going to do one case of which kind of, obviously we're going to go through the case itself. We're going to break down the physical exam. We're going to talk about differentials. We're going to go through results. We're going to come up with an assessment and plan. And then we're going to kind of go through the pathology of the disease. What's your guys' role? Obviously, participate. If I ask questions, shout out answers. If they're right, great. If they're wrong, also great. I think participation is really the way to go, and it's going to kind of help you evolve your knowledge. And then in the meantime, here's the link that has all the resources that you'll need, including the SOAP note, which is attached to the quiz. As I kind of promise, the quiz is fairly easy. I think that if you guys, pay attention, even if you zone out a couple of times, I guarantee you can pass the quiz on, the first or second time. If it takes you multiple times, that's fine. As long as you're kind of learning something and taking something away from this, that's really my goal for you guys, kind of using this as an opportunity to really evolve your knowledge from the comfort of your home, which is excellent. I always wish I had something like this when I was a pre-med student myself. All right, so here's a SOAP note form. We'll kind of break it down a little bit. And if you guys have any questions about this, let me know. If this time and you're lost at the end, I can kind of break it down for you. But SOAP kind of is an acronym for a few things. So the S for SOAP is subjective. So this is things like the HPI, the history of present illness, basically why or how the patient is presenting to where they're at today. And then the ROS is pertinent positives and negatives related to the chief complaint. Okay, so if somebody's coming in with a cough, we might ask if they have shortness of breath, or if they have a fever, or if they have a sore throat. Those are all things that would be pertinent positives or negatives associated with the chief complaint of a cough. Okay. Then objective, so those are things that we find, like the vital signs, like the physical exam. Then assessment is sort of what we've come up with in terms of evolving our differential diagnosis, and then plan is kind of intertwined with that. So if we say our assessment is a cough, and then we diagnose the patient with pneumonia, we'll want to say, okay, well, we're going to treat that pneumonia with antibiotics and admission, whatever we're going to kind of do to treat that ailment that we've kind of come up with. All right, so we're going to kind of go through these things. They'll make a little more sense in this presentation, how it's laid out. I know it's kind of hard to write a SOAP note off of the mini cases. This will be a little bit easier, probably more laid back in terms of typing out that note. All right. Okay, so let's see, where are you guys at in the world? So go up in on the top keyboard, you can go to annotate, and then you can click on stamp or whatever you kind of want, and kind of stamp where you guys are at. There's always lots of people from Canada. You guys are very dedicated. Let's see, we have Tennessee. Oh, I think the same Panama City person is here. We have a loop-de-loop in California. We have a Texas. Everybody else doesn't know how to use the stamp feature, or they're trying to figure it out. All right, so as to not waste too much time, let's keep it moving here. Wherever you guys are at, thank you for coming. I always appreciate it, and I think that I'm teaching for like the next 3 weeks. You guys are stuck with me, so I'll see you next week if you come back. But if you don't, that's totally fine too. I know it's kind of creeping into your guys' break. All right, so here's something that I realized I hadn't given you guys a read. I don't know if you guys actually read them or think they're interesting or not, but I thought this was a good kind of article. It's a personal narrative published in a journal about kind of ethics associated with AIDS, which I thought was cool. It was a cool kind of take on it. And I wanted to see, which kind of brought up the idea for me about doing ethics cases in this virtual round. Would that be something you guys would be interested in? Or it's like, I don't really want to hear ethics. Okay, cool. We have one yes. If you guys say no, you totally can. I'm just curious. Okay, cool. Yeah, so we can certainly talk about some ethics cases. I was thinking about that today. It popped in my head, and I was like, yeah, it might be kind of cool to talk about ethics in medicine and kind of get that perspective for you guys going into your applications and everything. So we'll kind of see when we can plan that. So stay tuned for that. But this is really an article that kind of talks about that, representing AIDS in comics, whether it's appropriate or otherwise, and kind of the stigma associated with it. So here is a video. It's actually published by the CDC, and it kind of talks about stopping HIV. I think it's a good article. It's a good video. It's a couple minutes, and I want you guys to watch it. So to save bandwidth, I'm going to turn off my video and play it for you all.
Immediately after I was born, I needed heart surgery due to the fact that I was a preemie. It was at a very difficult time in history when blood was not screened for the HIV virus. During that surgery, I received many blood transfusions, and one of them, or a few of them, had HIV. It was my mother's decision to keep that from me because she wanted me to live as much of a normal life as possible. Prior to 16, I had no idea that I was HIV positive. There was, when I did get pneumocystis pneumonia at the age of 12, my mother was very adamant, and there was a note on the door when any doctors or nurses were coming through the door, this patient cannot know his diagnosis. I'm happy that I was told later rather than sooner, because I think that it would have, it may have isolated me as a person, and I wouldn't be the person that I am today, being able to, tell my story.
Alex and I have known each other for probably close to 20 years now. We had lost touch for close to 10 years just because I changed schools and people lose touch. We reconnected through Facebook, and almost immediately when we started hanging out again, Alex disclosed to my girlfriend at the time, who's now my wife, and we were both very surprised. I think partly because we had a lack of understanding of the disease. Possibly imagine how hard it would be going through your still adolescent life, even though you learned at 16. You're still very young. How you cope with that, and when and how you tell your friends, or when and how you tell a girlfriend or partner. So the fact that he was able to do all those things and able to be as strong as he is and grow into the person that he's become, it brought about a newfound respect and admiration for him as an individual.
People that are HIV positive are no different than anyone else.
Educate yourself, educate those around you. You feel a lot less personal stigma towards the disease or condition, and individuals have it if you're educated. Let's stop HIV together. Get the facts, get tested, get involved.
All right, so I thought that was a good video. I don't know what you guys think. You can obviously put your thoughts and stuff into the chat. I thought it was a good kind of video because it shows this, diagnosis in something that's, not stigmatized and not kind of, maybe the norm in terms of that, and shows that there's lots of different people and there's truly a story behind the diagnosis, and it's not the status quo diagnosis. So I like that. If you guys have any other thoughts, feel free to throw them in the chat. I'd be happy to hear them. But let's keep going. I wanted to plug that in just so you guys could see it, not play it again. So here we go. Here's our case details, and it's a fairly brief case. So let's see if we can't deduce something from this small case. So this is a 23-year-old male that presents with general malaise, weight loss, shortness of breath. He notes that he was of normal health about 2 months ago until he gradually started feeling worse. The patient describes a productive cough. At night, he is noted to have night sweats followed by extreme rigors, which essentially is chills. No sick contacts, no past medical history. This patient smokes cigarettes about a half pack per day. Occasional alcohol use. The patient is adopted and has no known drug allergies. So with that information, let's see here. My first question for you is, what questions do we ask before proceeding? After reading that vignette, what questions do you want to know from this individual or their family that may be presenting with them? Sure, yeah, exactly. That's a great, his sexual activity is a good question to ask in terms of, not just because we know it's an HIV AIDS topic, but because that's something to ask in the social history regardless. Good. Anything else? We can talk about social history. We can talk about anything else that's going on. There is another thing that's associated with social history. Truly, two things that I think are important questions to ask. Yeah, if he's getting good sleep. Yeah, he's generalized malaise. We want to know what's the deal with that. Good. We can ask deeper questions in terms of that. Good. His diet, yeah, exactly. One important thing to ask if somebody's losing weight is if they're trying to lose weight. If we have Sally Joe and she's been going to the gym 3 times a day and exercising 4 hours a day, she's obviously trying to do that and trying to lose weight. Alcohol and smoking history. So that was listed. I think there's, yeah, good job, Hannah. I was just going to say that. Exactly. There's another part of that social history that we want to ask, which is drug use. Usually the question we ask is, are you using any illicit drugs? And then sometimes we'll be like, oh, well, just pot count, or, what do you consider illicit? That's something to ask, especially in terms of infectious diseases and different sort of viral diseases as well. We know that hepatitis can be transmitted through blood products, needles, things like that. Good. Any other questions that you guys want to know from this gentleman? And then my next question for you is, what differential diagnoses are we going to consider at this point? I know we don't have a lot of information. I will tell you, based on the questions that you guys have asked, he is sexually active, yes, with a female partner, and has been monogamous for the last several months. He is getting good sleep, though wakes up in the middle of the night. Often his diet, he kind of hasn't really been hungry lately. He's kind of lost his appetite, but does eat when he is hungry. Alcohol, doesn't really drink alcohol, drinks it occasionally, smokes about a half pack per day since he was 20. So that's a multiply 3 by half pack. So that's his pack-year history. Drug use, he has a remote drug use history. He said that he had used heroin in the past, but has gone to rehab for that and is clean from that. Okay. So given that new information, good questions, guys. I think you guys got a kind of a little more comprehensive history from that. But what differential diagnoses are we considering? Go ahead and tell me, and I will kind of type them up for us, and we'll see if we can't get a comprehensive differential here. So TB, sure. Yeah, shortness of breath and night sweats, definitely. What else for night sweats? We call them B symptoms, if you guys are familiar with that. Type of cancer. So that's lymphoma. You usually see night sweats, malaise. Good, we can consider pneumonia, certainly. What is related to his drug history or drug use history, even if it is remote? What are we considering with that? Yeah, certainly hepatitis. Good. We can consider endocarditis, sure. Any specific hepatitis that we're going to consider with this guy, or were you just saying hepatitis blanket statement and going with that? What else? So we have a few good things. We're pinpointing the weight loss. Really, anytime you see weight loss, we can just put cancer as a broad, but we do have to narrow it down. Anything else you guys want to put on your differential? All right, I'll take that as a no. Let's clear this and let's go to the next question. So based on our differential, so we had TB, we had cancer, we had endocarditis, we had lymphoma, we had hepatitis. What are we ordering based on that differential? What do you guys want? What tests do you want? Somebody said pneumonia. So choose the tests that are going to rule in or rule out that. Yep, we can get a chest x-ray. Absolutely, I agree with that. Especially because he's fatigued. He kind of has a cough. Good. And some shortness of breath. So we got a chest x-ray. What else? He has malaise. He's tired. What do we think about with fatigue? What's something that we can consider hematology wise? Yeah, good job, Joshua. We can certainly consider RBC count and think of something like anemia. So we'll want to get a CBC. Yeah, good. We'll get a CBC. It's a complete blood count. It includes our usually our cell indices. So it includes our red blood cells, white blood cells. There's a differential which counts all the different types of white blood cells, and then also there's a platelet count and kind of the red blood cell indices in there as well. Okay. So what else? We said cancer. What else are we going to rule in and rule out? Whoever said hepatitis, what are we testing for to rule in hepatitis? We can get two things. I would get biopsy of a swollen lymph node. Yeah, I mean, if we have a lymph node to find, sure. So yeah, we'll want to pinpoint the liver. We can get a liver ultrasound. We'll ultrasound the liver, and then we can get a hepatitis panel. So good job with that. What about endocarditis? Whoever said endocarditis, how would we rule in or rule out that? If we're suspicious of endocarditis, in fact, if we meet the major and minor criteria. EKG can show the electrical activity. Think of ultrasound of the heart. What do we call that? Yeah, good. We'll get an echo if we want to rule in or rule out that. Good. I think we have good tests here. Obviously, we'll do our physical exam first and then kind of go from there, but we do want to kind of put that in the back of our minds. And then from the history, let's pinpoint those things that are important. And what I want to do for that is I want to go back here and I want you guys to pull out your pens and highlight the things, being very meticulous to only highlight the words that matter, that are important from this history. Okay, so we have highlighting on smoking cigarettes, good. Shortness of breath, productive cough, good. I agree with the weight loss. It's always cause for concern. We have night sweats, absolutely, followed by rigor. So we have a little bit of sweats and then chills. He's adopted, good. That gives us, a little bit of a question mark in terms of his history. I would say this is always cause for concern too, this malaise. It's like, I can't really pinpoint it, it's vague, but, and then also we can kind of pinpoint the duration as well. It's been going on for 2 months. So it's a long time. It's not acute. It's not acute. It's kind of this chronic thing that's been going on. Then I also think it's important, even though it's basically unremarkable, this tells us like, okay, this guy's usually healthy and now he's not healthy. Plus he's young. That's what I always think is important. I always kind of pinpoint the age of the person because we can kind of classify these frameworks based on internal medicine, based on kind of the age of the patient and, you know, their sex potentially. All right, good job with that, guys. Let's keep going. I'm going to give you guys the physical exam here. So let's kind of jump to that. So what are we pinpointing here? You guys said a few things, but what do you want to look at in terms of the physical exam? What do you want to know? I know you guys gave me a few tests, but what are we looking for the physical exam? If we're looking at things like anemia, what do I want to look at it on the physical exam? If I'm ruling out endocarditis, what do I want to do in terms of the physical exam? We talked about pneumonia, good. So Adam says breath sounds, exactly. We want to listen to see if there's crackles, see if there's wheezes, see if there's rhonchi. Crackles sound like Rice Krispies, and then rhonchi kind of sound like snoring, basically. We can see wheezes. You guys probably know what wheezing sounds like. What about for the endocarditis? Somebody said endocarditis. What are we listening for there? Yeah, murmurs, exactly. We can definitely listen for presence of S3. That's more of a fluid overload status, and then S4 is usually for like a stiff ventricle. So that is a little less specific for endocarditis, but we would want to listen for murmurs for sure. That can kind of clue us into something going on in terms of that, especially regurgitation of the valves. Anything else you guys want to know? What about for anemia? What are we looking at for in terms of anemia? How do we tell if somebody's anemic from a physical exam? I know you guys know this. Don't think too hard about it. I even taught you this and yeah, good. So Sammy says skin pallor. And then what's the other sign that you can look at in the eyes? It's also kind of a pallor. Yeah, it's a subconjunctival pallor. So you kind of pull these down and see if it's, you know, red. Mine's pretty red. Somebody who's anemic, it's pretty pale. Okay. All right. So here's your physical exam finding. Let's kind of go through it. Let's dissect it. So the patient is febrile. Yikes. Also tachycardic. Double yikes. They're normotensive though, and you know, breathing at a regular rate here. The patient is cachectic, bad, which means you know, skinny essentially, kind of losing muscle mass. And then also has this temporal wasting. So right here, they're kind of losing the temporalis muscle. Dry mucous membrane, so perhaps a little bit dehydrated, and the patient has thrush, which is bad. You should never see thrush in somebody who's an adult. Sometimes we see it in babies. Babies haven't built up their immune system, but you should not see thrush in an adult. The thing about thrush is you take a tongue depressor, kind of scrape it off, and it comes off easily. We differentiate that from something called leukoplakia, which it can be a precursor to squamous cell carcinoma in the mouth. That doesn't scrape off. So those are two kind of things we want to have on our differential there. The other thing is the patient has generalized adenopathy. So there you go for the person that wanted to pull out their needle and biopsy. I think we have a future surgeon in the room. The lymphadenopathy is most prominent in the axilla, the groin, and the anterior chain lymph nodes, okay? The patient is tachycardic with a regular rate and no murmurs, rubs, or gallops, okay? So that is promising in terms of our maybe ruling out the endocarditis. The lungs, the patient has diffuse rales, scattered wheezes heard throughout. So no bueno, that is not good. So the patient kind of has crackles and then kind of wheezing heard throughout. So there's not a specific area, it's just kind of all over. And the belly is tender to palpation. So we have a lot going on here. So what tests do you guys want now? Is there anything else we want to add to what we've already kind of talked about based on these physical exam findings? Anybody? Or any questions that you guys have? All right, so here's our lab. So you guys ordered your CMP, your CBC. Somebody told me a CBC, so we'll start with that. We'll start here. Okay, so the white blood cell count, very low, 1.3. We should be around 5-ish to 11. This patient's very low. We call that leukopenic. If it's high, we call it leukocytosis. If it's low, we call it a leukopenia. Okay, the patient is in fact anemic, 11.1, you know, not incredibly anemic to the point where we, you know, need to transfuse this guy, kind of on the border. And then we remember that our normal MCV is around 8 to 100. So this makes this kind of anemia. What do we call it? For those of you that remember, I have a slide to kind of remind you next. But what do we call this? If we saw a small MCV and we're anemic, what do we call that? Yeah, good job, Seema. Exactly. So it's a microcytic anemia, definitely. And we're going to go through that here in a second. But before that, the one thing that we really have going on here is a slight hyponatremia. So a slight low sodium. Everything else is kind of normal, even normal potassium and normal chloride and normal CO2, normal BUN and creatinine and normal glucose. We have pending blood cultures, especially if somebody's febrile. And we're going to talk about that because the patient kind of met criteria for one thing that we consider in terms of sepsis, in terms of SIRS. Okay, so we met a little bit of criteria in terms of that. We're going to talk about that here. First, what we're going to talk about is this anemia. You guys pinpointed it exactly. So anemia, we say, you know, if we have a low hemoglobin, we base it off our hemoglobin here. Some people base it off of hematocrit. Some people are hemoglobin people, some people are hematocrit people. But what we're looking at next is we say, okay, we have anemia, we have a low hemoglobin, all right? Normocytic, as I was kind of saying, is 80 to 100 femtoliters. Our units are femtoliters, FL. And then if it's less than 80, we call that a microcytic anemia. And if it's greater than 100, we call that a macrocytic anemia. And it makes sense. This is one of those things that's actually named appropriately in medicine. So micro meaning small, that's a small anemia, small cells, and then macrocytic are large cells. Okay, so we're kind of in this bucket over here, so we'll kind of focus on this today. As we kind of talked about, they kind of make this cute mnemonic over here, tail. So thalassemias, so we have alpha thalassemias or beta thalassemias, kind of depends on the chromosome it's based on. So alpha genes or beta genes. Anemia of chronic disease, iron deficiency anemia, or lead poisoning. So, you know, we can have other things kind of show up as a microcytic anemia that don't follow the textbook, but these are some of the things we might want to think of, okay? All right, then the next thing that we're going to talk about is this idea of SIRS versus sepsis, okay? So we know that if we have greater than 2 of these SIRS criteria, we have SIRS, okay? So here are the SIRS criteria, and I'm going to go through them, and you are going to tell me, do we have these criteria or not, okay? So do we have a temperature greater than 100.4 or less than 96.8? So just yes or no. Yeah, good. Agreed. So the patient, I think it was like 101.7. Then the other one is a heart rate greater than 90. Did we meet that one? Yes, redemption, Sammy. So the next one is respiratory rate greater than 20. We didn't get a blood gas, so we won't have this one, but did we have a respiratory rate greater than 20? No, good, excellent. And then how about a WBC count greater than 12 or less than 4, or greater than 10% bands. So we didn't have a bands count, but we did have a WBC. If you remember, it was 1.4. So Sammy is absolutely correct. That would be yes. Okay, so we only need 2 of these to meet SIRS criteria. And then in your head, you're probably like, well, what is sepsis? What is SIRS? I'm confused. So basically what sepsis is SIRS plus a source of infection. And you might say, okay, well, do we have a suspected or present source of infection? Okay, and the way we this is what's going to come. Okay, some of you guys asked for a chest x-ray. That's what's going to come. So for instance, you guys can answer this question after we see this chest x-ray in a second. You tell me if there's in fact a source of infection. Okay, but first, here's kind of, this is what normal looks like. Okay, I've showed you this slide a couple of times now. Here's our guy, a stark contrast. What do you guys see, or what do you guys think? Is this normal or abnormal? Good. So you guys are saying abnormal. The first thing I always do is kind of identify what kind of film we're looking at. Okay. So what we see here is obviously when we're looking at this, this is going to be the patient's right, and this is going to be the patient's left. And what we're looking at here is this looks like an AP film, so anterior to posteriorly shot. And we can look at certain things. So we can look at the airway here and see, okay, it's fairly midline, great. When we look at the lungs here, we see this patchy infiltration kind of diffusely and bilaterally. We don't see any fluid at the costophrenic angles. That's these guys down here, the costophrenic angles. We do see a normal air bubble here, that's fine. Let me clear this before I make too much of a mess. We don't see any hilar adenopathy. The bones look okay. We see good inspiratory effort. So we see, you know, if the kind of airway was up here, we would say, you know, poor inspiratory effort seen. But this is kind of a well shot film, and we see this diffuse patchy infiltrate. And when we see it here, here's a lateral that gives us a better idea. And it's kind of, you know, in fact, diffuse. So here's our lateral. This is the patient's left side over here, denoted here. So we see our AP and lateral showing that diffuse patchy infiltrate, which is absolutely abnormal. So let's go back to our last slide here. And now you guys tell me, do we have a source of infection? Good. So we met SIRS criteria. Good. We had greater or equal to 2 of the SIRS criteria, plus we have a source of infection. So therefore, that's when we call it sepsis. Okay. So what we do now is we place this patient on broad spectrum antibiotics. We get a sputum culture if we need to, try to pinpoint the actual bug that's causing this. But as you'll kind of see, if you've been in hospitals, there's a huge campaign to kind of identify sepsis when patients meet that criteria to prevent, you know, complications associated with it. Okay, so now you guys have a better idea of what this sepsis SIRS, and then we call severe sepsis when we have hypotension or end organ damage as a result of this. Our patient doesn't necessarily look like that just yet. Okay, so there's our chest x-ray again. Here's our anatomy again, just to kind of remind you. Remember, the right lung has 3 lobes. It has that middle lobe, whereas the left just has the upper and the lower lobes. And we know that the lobes of the liver are kind of separated by those fissures. You'll see this in your future, if your future school does a cadaver lab, you'll kind of see those fissures between the lungs. And then you'll see kind of this delineation between the ribs and what it looks like in terms of where the lobes would correspondingly be located. Okay, so here's a few more tests. So we got this, you know, we got this workup. We say, okay, there's an infection. We know that the patient has a drug use history. So we are going to test for hepatitis, yes, but we want to test for other infectious diseases, especially given that we have a patchy infiltrate. This patient's pretty sick. So we kind of escalated our treatment, or our testing rather, to test for HIV. The first test being the kind of screening test being an ELISA test. Okay, this is kind of this reaction that we see here over on the top image, where what we're doing essentially is we're having a this antigen antibody specific reaction that reacts with a conjugate enzyme and a substrate that causes a color reaction and then correspondingly an emitted light wavelength of light. Okay, so that's what's causing this reaction. It's called enzyme-linked immunoassay. It's called ELISA for people like me that are not that smart. We just call it ELISA because we don't want to say all the words. But as you can see here, our patient was positive. So that tells us, okay, our screening test was positive. Let's do a confirmatory test. And that's what the Western blot is. And we're going to see that down here on the bottom, obviously what we're doing is we're kind of, it's in we're placing our antigen samples, our serum into a separation gel. We have the proteins that become separated and fixed, and then we see this result here, and we get, obviously before that we're immunostaining it, and there's a labeled antibody that kind of shows us this progression of the actual proteins. But what we're seeing here and what we're looking at is this image over here on the left. So we're looking at this here. That was a horrible arrow. I'm going to delete that. But we're looking at this image here. Specifically, there's these different wells. This one is the positive control. Okay, number one is the positive control. Number two is the negative control. And lane C is our patient. Okay, so what we want to keep in mind is this here. We're not going to worry about what indeterminate means. Not really applicable for our discussion right now. But what we're seeing is if we have bands at either the P31 or P24, P24 being important because it is a core protein, P31 being important because it's an integrase part of the HIV, virus, or you have bands positive at 120 or 160, we call that a positive. So some wise person out there, please tell me, is this positive or negative for patient C, our patient that's running C? Good, excellent. So you guys say positive. I agree with you, because what we're seeing here, for those of you that are like, oh, how is this positive, and you're going cross-eyed, because these are complex tests. So what we see here is we're looking at P31, that's our friend right here. We see a kind of light positive. If you squint hard enough, you're like, okay, great, it's positive, it looks positive to me. But what's more important is that we can have there's an or statement, and we say, okay, if it's positive at P24, that's the other or. It's very, very positive here. So we have that. So we have P31, it's kind of lightly positive. If we were even unsure, we say, okay, that's very positive. So we don't even need P31 at this point. Okay, and we need bands at GP160 or GP120. Okay, so we come up here, we look at our GP160, that's positive, and our GP120 is also positive, GP120 being an envelope protein. We're going to talk about that at the end. So we have a very positive Western blot here that confirms our diagnosis of HIV. Other things that we want to consider in our follow-up testing is we want to get RNA PCR, that's what we call our viral load, to see how many copies of the virus are in the patient's body. We can kind of, obviously tailor our approach, our treatment to that. Also the CD4 count, that's going to become important when we talk about, is this patient actually in AIDS? Then before we do any treatment, you guys probably know the treatment is highly active antiretroviral therapy. You probably see 1,000 commercials about it a day on TV. If you still watch TV, I don't. I stream. I'm a modern day millennial. But what we want to do is we want to get the PPD skin test, which I'm sure a lot of you have gotten at that point where they kind of stick the needle, you know, they make the bleb and see if you react to the purified protein derivative to see if you've been exposed to tuberculosis or not. Otherwise, we can do an interferon gamma assay. It's more specific for TB, more expensive though. And that's just to make sure you don't have latent TB that's going to sort of wake up and run rampant in your body once we are treating the HIV or the AIDS. Okay, we're gonna do another infectious disease workup, kind of rule out other etiologies that are gonna affect our treatment, and we don't want to kind of come back. All right, so let's keep going here. And then one thing that we want to remember here, we're talking about obviously leukopenia here and where we're at in this algorithm. And in fact, I had to use the algorithm today in hematology oncology when working up a patient with leukopenia. And you have to kind of take into consideration all of these. So basically, in this algorithm, it's like, okay, does the patient have a concomitant anemia? Kind of, question mark. So if that's the case, to kind of lend you in this bucket, the patient has a slight anemia. So, you know, it might even be here. Does the patient have thrombocytopenia? No, they have a normal platelet count. That's what that is. Thromb is kind of a prefix for platelets. And then we'll say no. So we're kind of going down this branch, even though the patient was slightly anemic. So we're here. And then things that we want to rule out in patients with leukopenia is nutritional deficiencies. So things like copper, iron, B12, folate, things like that can cause low white blood cells nutritionally. And then obviously you'll see here's our friend or not friend, HIV. And that's kind of in that algorithm there. Other things that we may want to consider is, you know, maybe lupus. So we might get an ANA, which is kind of over here, anti-neutrophil antibody. This is so here it says anti-neutrophil, anti-nuclear antibody is what we really want to test for ANA. It's if you remember, it's a good screening test. So it's obviously sensitive but not specific. And then we can look for things like myelodysplastic syndrome, so problems with the bone marrow, and PNH as well. We talked a little bit about that when we talked about anemia, but we're not going to go down that rabbit hole this time. So really what I want to show you is when we're looking at problems with leukopenia, we should have a broad differential so that we can rule in or rule out all of these things. Because, you know, just because one thing is going on doesn't mean multiple things can't be going on. So we really have to have the full picture here. All right. So there's kind of a workup in terms of that. All right. So our assessment and plan, what diagnosis are we going with? And remember, there's more than one diagnosis here. If you think back, okay, the patient had a few things going on. Remember our lab work. What's our first diagnosis we're going to go with? Go ahead and throw it in the chat. This one's fairly easy. Good, HIV. I agree with you. Yeah, I think it's HIV. And this is where we're going to kind of have a lesson on it, because the patient had a PCP pneumonia, pneumocystis jirovecii is the bug. It's, some people abbreviate it PJP. It's an AIDS defining illness. So we're going to get the CD4 count. It's probably going to show that it's less than 200 because that's how we defined AIDS. Or the thing about it is if the patient has, you know, even in the 300s, 400s, but has a PCP pneumonia, that's an AIDS defining illness. So that is AIDS, regardless of the CD4 cell count. So if you have an opportunistic infection, we say that's AIDS, regardless of what the CD4 count is. Okay, I hope that made sense. If that doesn't make sense, just tell me to explain it again. Okay, so we have an AIDS defining illness here. We didn't get the CD4 count, but we can say with a good degree of confidence that this is PCP pneumonia. We're going to treat it with Bactrim, that's TMP SMX. We had that positive ELISA, which was a screening test, and then the Western blot, which was our confirmatory test. And then we're going to get our infectious disease workup prior to the treatment. And then we know that our treatment is highly active antiretroviral therapy. So usually what we use is two nucleoside reverse transcriptase inhibitors, and then one non-nucleotide reverse transcriptase inhibitor. So basically what we're doing is we're inhibiting, that's right here, we're inhibiting this reverse transcriptase part of the HIV virus. All right, so that's what it's acting on. And then we have these other things. So the protease inhibitors inhibit the protease enzyme. These are the two that we just talked about. And then the integrase inhibitors kind of inhibit the virus from being integrated into the host genome. Okay, so these are actually named appropriately for once. So take advantage of when that happens, which is like almost never. The next thing are hyponatremia. So remember we had a sodium of 133. We call it euvolemic based on the patient's hydration status. So this patient looked like a normal volume, so we call that euvolemic hyponatremia. And then finally, our slight anemia, we can call that microcytic anemia. And obviously we'll monitor that. That might correct once we start to treat the disease. It might get worse even with treatment, but we'll kind of play it by ear. And we can transfuse the patients less than 7. We might have a higher threshold, maybe 8 if this patient's sicker, but we'll kind of keep watching that. Nothing to do for that right now. All right, so I have a few more slides for you guys, and some of this stuff has been covered because we kind of talked about it as we went. But the definition and classification of HIV is a retrovirus, so it's a reverse meaning retrovirus, and it targets CD4 lymphocytes. Okay, so that's why we see the CD4 count drop. And I'm going to show you a graph that kind of shows the comparison of that. But there's 2 different HIV viruses. HIV-1 is more common. HIV-2 is kind of endemic to areas of Africa, is less common, more common in pregnant women, I believe. But what we define as AIDS is CD4 less than 200, unless there's an opportunistic infection, like toxoplasma, like pneumocystis jirovecii, different things like that are AIDS defining illnesses. I'm going to show you a slide about that as well. So what's the best initial test? That's our ELISA. That's our friend ELISA, where we get that immunochemical reaction, and we see that color reaction due to that antibody antigen reaction emitting at a certain wavelength. Okay, so that's a high sensitivity test, has moderate specificity, but it detects that anti-HIV antibodies. So really that's what that is looking for. The thing about it though is it's moderate specificity and high sensitivity, yes, but it may take antibodies up to 6 months to show. So if we test in a period where it's uncertain, it may not show. Okay, what do we do to confirm? Okay, that's the Western blot. We talked about that as well, and we kind of broke that down, how we're looking at the proteins on the HIV virus itself. We're going to talk about those proteins as well. Other things we'll need imaging, we'll need the CD4 count, and we'll need the labs, and we might want to look for those opportunistic infections. Okay, here's kind of a cartoon here talking about how the virus gets in. I'm going to show you a different one here in a second that's going to make more sense to you, which is this. Oops, I guess not. So here's the HIV structure. Okay, so remember our old friends GP120 that we were looking on in the Western blot? Oh yeah, here it is. This is what we're testing for. So GP120 is part of the envelope of the HIV virus. So we see these spikes here. It might be kind of reminiscent for you of COVID. COVID kind of has spikes. This is a little bit different. GP120 really helps with the fusion and entry of the virus into the target cell, and that's part of the envelope. That's what this EB means down here. Also our friend GP41, that's really for anchoring and kind of fusion into the cell. That's its role there. And then the other ones that I really want to kind of talk about here are this core protein, the P24. So that's really as part of the capsid, part of the core inside of the virus. And then there's obviously an important part here. It's not depicted in this actual cartoon, but this pol, which is for the polymerase, which has its own reverse transcriptase. This P51 encodes the reverse transcriptase that is also kind of takes the RNA and puts it into a proviral DNA. So that's that idea of taking the RNA and putting it into DNA. It has its own polymerase. So that's what kind of makes the infectivity a little bit higher in terms of it comes with the machinery that it needs. All right. There's the other things here. Here's the protease that we kind of talked about. So remember, we had the drugs that target this, and here's our integrases here as well. So here's the genome, and then there's that reverse transcriptase, which kind of correlates to this. All right. So there's kind of an overview of that. There's lots of things, but we kind of delineate it by the GAG, pol, and the on, which is the envelope protein. All right. All right, here's this kind of graph here that shows what I was talking about earlier. So we see kind of this inverse relationship between the virus and the antigen showing infectivity. We see that the CD4 lymphocytes kind of hold strong. They're kind of army hold strong for a while, for a lot of years, and then kind of declines after time. You know, that is when we see those CD4 counts drop, we really characterize that as opportunistic infections and also malignancies. We can see lymphoma associated with HIV, which is also an AIDS-defining illness as well. Okay. All right, so here's that opportunistic infection that we were kind of talking about here. It's really AIDS-defining illness. These aren't all infections. A couple that I want to draw your attention to here is this pneumocystis jirovecii. That's what we were talking about. So we had hypoxia, we had a cough. Other things that we can talk about, whoever said TB, well done. Somebody said TB with night sweats. I think you're brilliant, excellent job. It's something that we want to kind of pinpoint here in terms of HIV as well. Other things, remember our friend the thrush, rutro, there it is, the candidal infection at the mouth. Remember, adults shouldn't be getting that. So we might see a little bit of dynaphasia, which means it hurts to swallow or problem swallowing. And then something else that we can see here is primary CNS lymphoma. That's one of the malignancies that we see associated with AIDS as well. So these are, you know, these aren't, you know, hard and fast CD4 counts that we see this with. It's just kind of a rough estimate. You know, obviously, can we see Candida with a higher CD4 count? Yeah, sure. Or lower, yes. But it kind of depends. So these are kind of roughly. And a lot of times, if we have, you know, a CD4 count of, you know, less than 200, often we'll prophylax, meaning we'll try to prevent, you know, PCP pneumonia or different things, cryptococcus, things like that, based on the CD4 count. So we might give Bactrim prophylactically. All right. All right. So here's another one with kind of the treatment. It's just another chart that kind of shows that prophylaxis, just what I was talking about. So for instance, PCP pneumonia, we kind of talked about, we'll prophylax with Bactrim. The good thing about it is for toxoplasma, we're also kind of prophylaxing with Bactrim, which is great. And then obviously you'll see these other things. It's important for our HIV patients to have their influenza vaccine. Also, because they're high risk, they'll get the pneumonia shots as well. They'll get the PCV 13 followed by the 23 later on to kind of build up their immunity. And then we can do like suppressive acyclovir for like HSV. For our patient with the esophagitis, we can give fluconazole. But yeah, this is just kind of showing this, you know, how we prophylax for opportunistic infections and HIV. All right, I believe this is my last slide, and then you'll be rid of me for the night. And this is just kind of talking about risk factors. Obviously, treatment here. When we talk about risk factors, we talk about things like unsafe sex practices. We talk about injections or needle use. Our patient, you know, who knows where it could have came from at this point. You know, the patient did say he was monogamous, though we didn't ask about his prior sexual history. He did use needles in terms of heroin in the past, so perhaps that's where it came from. And we definitely want to test for that hepatitis to make sure there's no co-infections there. That can be, you know, pretty disastrous for this patient. But we also see that accidental needle sticks. And then what's the transmission? Bodily fluids. Okay, remember from the video that patient of whom had HIV from the patient's mother, which was transmitted because it's an IgG antibody. It can cross the placenta and go to baby. That's often something that's tested for in pregnancy is HIV, also hepatitis. Okay. How do we treat it? It's HAART, highly active antiretroviral therapy. Remember, we have those things that target the different parts of the HIV virus. Okay, so we have our reverse transcriptase inhibitor, we have our fusion inhibitors, we also have our integrase inhibitors that prevent it from being integrated into the genome. And then, you know, obviously we have our protease inhibitors that inhibit that protease enzyme. So that's a little bit of a breakdown of it. I don't want to go into too much details of specific drugs and all of that. That might make you guys go to sleep. So I don't want to do that to you. But that's a little bit about the infectivity and things in terms of, you know, etiology and risk factors and transmission, as well as treatment. All right, so that's what I have. Let me launch the poll here real quick for you guys. Let me relaunch it. And you guys can answer for me, if you will, how you feel kind of an hour later after I've talked a good deal about HIV and AIDS. All right. Excellent. So let me share this with you guys. So nobody said they know nothing, which is always great news. A lot of you guys said you know some. So the vast majority of you, 79%, I'm very humbled by that. I appreciate your guys' honesty. And I think that that's great, especially being at your level. You know, I don't even know a lot about HIV and AIDS. So if somebody said they knew a lot, I would expect you to teach it to us next week. So you guys are all off the hook. But what I'm going to do now, I'm going to stick around for a few minutes here, and I will answer any questions that you guys have about HIV and AIDS, about you know, med school, about anything like that. I'll stick around for that. Looks like we have one question. If the bands, if they have bands for both, is that indeterminate or still positive? I believe it's positive. Let me look and see what actually is deemed as indeterminate on that one Western blot slide. Because I think indeterminate is like when you have one of the other proteins, I believe, but let's see. Let's go back. Bands present, but pattern does not. Yeah, so that wouldn't be indeterminate. That would be if you have certain bands present. So say you have like all of these bands that are here are representative of a protein of the HIV. So it would be like basically if you had, so say, for instance, I can tell you what one indeterminate would be. So remember, we need either P31 or P24 and bands present at this or this. So say we have the core protein and then we don't have GP160 or GP120. That would be indeterminate. or if we have GP120 and GP160, but we don't have one of these, that would be indeterminate. So we can have both bands for GP31 and GP24 because GP24 is for the core protein, and GP31 is for tissue tropism. So that would basically be a pattern where it's like, okay, look, it looks like we have these glycoproteins that are positive, but it doesn't look like it's following a pattern of which makes it truly positive. So yeah, assumably that would be indeterminate. We might have to test again for that if that was the case. That's an excellent question. Okay, you mentioned earlier that some people use hemoglobin levels and some people use hematocrit. I'm not very sure, but yeah, so exactly. If the patient is dehydrated, we can get kind of a get this false hematocrit in terms of that. So it would look like the hematocrit's actually higher. So that's what that would look for. It wouldn't necessarily look like an anemia. It might look more like a polycythemia. If we had this similarly, if we had a dilutional effect, that might look more like an anemia. If somebody's kind of dehydrated, it might look more like a polycythemia or increased hematocrit as opposed to an anemia. Is it specific? No. The hematocrit is not necessarily specific, but if there's other factors involved, obviously it's not necessarily specific. If you had a dilutional effect, someone, if you went out right now and drank a gallon of water, I would assume that probably you might have a little bit of a dilutional effect of your hemoglobin. Similarly, in the same way when we test for BUN and creatinine, sometimes if somebody's extremely dehydrated, we might see a high creatinine or a low GFR because they're dehydrated. That happened recently, and someone was like panicking. My GFR is low, but it's like, no, you're probably very dehydrated. If we, hydrated you and then redid it, then it might be a little bit normal. I hope that answers your question. Anybody else with questions out there? How do you remember all the medications in pharmacology? Some people have different mechanisms. You might have heard, there's this thing in medical school people use, it's called Sketchy. I don't like it. I didn't use Sketchy, and everybody thought I was crazy for it, but Sketchy is kind of this like cartoon where like things stand for other things, but for me that's like too much work. It's like I don't want to remember something for something else. I just want to remember for what it is. Admittedly, HIV drugs are pretty tough, so are cancer drugs and stuff, but you'll kind of remember it with repetition. Same thing with a lot of drugs. A lot of what you're going to learn in school is a lot of microbiology and a lot of pharmacology, and you'll kind of remember it as you go. You'll kind of evolve your knowledge in terms of that with a lot of repetition. Because you'll remember, like, for instance, AZT. AZT is part of the nucleoside reverse transcriptase inhibitors, which is zidovudine. It's pretty common backbone for the treatment of HIV. So, and you'll kind of see that with in a lot of the way we learn medications and pharmacology in school is by its side effects. So you'll learn that later, like lisinopril, the ACE inhibitors often cause a cough. So if somebody comes in, they have high blood pressure and they're like, I have this weird, tickle in my throats, because of the buildup of bradykinin. So we want to switch that to, an ARB or something else, a calcium channel blocker maybe, to get rid of that. So you'll kind of remember it over time through repetition. You know, I don't expect you guys to see this PowerPoint of all these things and be an expert on pharmacology of this. For you guys, I think it's important for you to know in terms of pharmacology, these different ways we treat HIV based on the properties of the actual virus. So we're targeting these different parts of the virus to really reduce it. So it's not a matter of remembering all of these things, but kind of pinpointing these certain things, because once you kind of know the basic foundations, you can build upon that. So I would say my short answer is a lot of kind of repetition of a lot of these things. Any other questions? If you guys have questions about med school, you can shoot. You're very welcome, Matthew. Thanks for coming.